It will kill the audio.
Be here.
It kicked me out multiple times. The projects, we're gonna start in just a little bit. We're having difficulties with the Zoom in the room. One moment. to do it here as a standing here so quick. Not this, it's just
Where
where would you want to put it? Can you plug into this laptop? the display?
So this showing.
It should show,
here.
you go forward, yes, so go forward one and then back and we'll just make sure it's.
So audio.
Here.
Audio is coming from here.
Okay, so I'm just gonna leave this here and he knows. Yes.
This. Okay.
Great, everything's right here. Okay, so just use the laptop. Great. Hi, everyone. We apologize for the delays. I think our first time being doing a new hybrid of grand rounds, which is really fantastic to be live in person and online. But just some hiccups. IT has now resolved the problem. I want to introduce our amazing lecturer who we have visiting us as part of our Global Grand Round series. This is a series, as you guys know, with 5 presenters that we're going to have over the next couple of months who have come and visit us from multiple different international global locations to provide their expertise on mental health and mental health research. Dr. Lukoye Atwoli is a professor of psychiatry, dean of Aga Khan University Medical School in East Africa in Kenya. He is also the deputy director of the Brain and Mind Institute, and he also practices psychiatry at the Aga Khan University Hospital. He's an honorary professor in the Department of Psychiatry and Mental Health, as well at the University of Cape Town, and collaborates with colleagues all over the world in research and teaching in psychiatry and mental health. He trained at Moi University before undertaking specialist training in psychiatry at the University of Nairobi, where he completed his dissertation in exploring post-traumatic stress disorder among concentration camp survivors in Nairobi. He later earned a doctorate in philosophy, his PhD, from the University of Cape Town in South Africa, focusing on epidemiology of trauma and post-traumatic stress disorder in South Africa. He's widely published, and current research interests are focused on trauma and PTSD and the genetics of mental disorders, but he's also very active in research in children's and youth mental health on HIV, as well as HIV and mental health. He is the president of the African College of Neuropsychopharmacology, among a number of organizations around the globe. He's a local Kenyan celebrity as well, I might add, in psychiatry. I'm really pleased to introduce him, and we thank you all for your patience.
Thank you. Thank you very much, Maria, for the very kind introduction. And these IT glitches happen all over the world, so we are not an exception here in the US. I'm going to speak today about the mental health landscape in Kenya, and basically look at where we are coming from, where we are, and where I think opportunities exist for collaboration and for working together on the continent and in Kenya. So I begin by foregrounding this presentation because history, and I think we were having a discussion with Dr. Dave Henderson about why history is important. History is important in the practice of psychiatry, in the practice of medicine, and history is important when you're dealing with an individual, knowing where they're coming from, in order for you to be able to address some of the problems that they have. And this picture is of African, or actually Kenyan soldiers in the Second World War in then Burma. And my grandfather fought in Burma. I don't know if he's one of the people in this picture. It looks like he could be the guy squatting right in the middle of the picture, but I'm not sure that he's the one. But he did fight for the British colonial government during the World War. And so this is part of the foregrounding of what I'm going to talk about, and we will see why that might be relevant. But I begin by pointing out that there were indigenous systems of medicine in East Africa, including mental health systems, way before the colonial powers came to East Africa. And there were three categories of people involved in healing. And these included herbalists who would get medications from plants and mix them and use them to treat certain conditions. But we also had diviners who allegedly could tell what is going to happen in future. And they could tell your fortune, and they could tell what's happening with you when things are not going wrong for you, when things are not going right for you. So you could think about them as the mental health providers at the time. And then we had witch doctors who many people would consider to be malevolent, people who used to cause harm to other people. However, they could also be asked to reverse some of the problems that were caused by other witch doctors. But there were other forms of traditional treatments as well in the pre-colonial period, which included craniotomies in certain communities. So among the Kisii in Western Kenya, they would drill holes in the skull for people who had chronic headaches, especially after experiencing trauma. So they classified headaches into different categories. And those that were resulting from traumatic events like head injury and so on, they would do craniotomies, drain blood, drain fluid to relieve the. There was no clear demarcation at the time between what we call mental illnesses and physical illnesses at the time, but there were clearly distinguishable treatments that were applied to one kind of illness and not to the other. So illnesses that were predominantly behavioral, for instance, would get different kinds of treatment from illnesses that were predominantly somatic. But obviously then there were also supernatural attributions for these illnesses. In the mid-1890s, the British came to East Africa, and Kenya became a colony towards the end of the 1890s and remained so for 70 years, up to 1963, when we gained independence. So in 1910, there was a smallpox isolation center in Nairobi, which was then converted into the Nairobi Lunatic Asylum to address some of the mental health problems among the settler community. And I'm the first person to say that when the British and many of the colonial powers were sending out people to colonize countries that are considered, or areas that are considered uncivilized, they didn't send their best and brightest. So many of them were people with problematic issues back home in the UK, and they ended up doing interesting things in Africa. And so some of them were considered to be mentally unwell and required treatment. And so this asylum was created to take care of them. Later, they started admitting the local population as well. Africans would be admitted there, but their treatment was segregated at the time, and they would be treated very differently from the European counterparts. And then after the First World War, Second World War, the facility was used to treat people who had a lot of the ailments that were related to the trauma exposure during those wars. So one of the famous patients at the Mathari Hospital, as it was later called, was a freedom fighter called Elijah Masinde, who was admitted in the hospital because he said the British are going to go and Africans will rule the country. And they considered him to be delusional. So he was admitted in that hospital for treatment of his delusions. And he was just one of the many Africans with contrary opinions from the colonial government that were locked up at the hospital because of their political opinions. At the time, what we could call the researchers at the time, who are really just medical officers, some amateur anthropologists, amateur sociologists who were living in the country. They were the ones who populated the then academic literature with justifications for the treatment that these people were getting. So people who were saying that Africans could rule were classified as being delusional because of some of the research that I'm going to show you that was published by these individuals. One of the primary ones was J.C. Carothers, who wrote a monogram on the psychology of Mau Mau, and these are the freedom fighters that were fighting against the British rule after the Second World War. So these would be the people who fought with my grandfather in Burma and in other areas of the world during the Second World War. Carothers argued in the psychology of Mau Mau first he gave a disclaimer, obviously saying that that his competence, his personal competence for writing this report is limited. So he made that disclaimer very early on. But in 2 months, he traversed this vast area in the middle of the country and managed to arrive at certain solid conclusions about the nature of the population and the nature of the people who are resisting British rule and how they ought to be treated. So this is what he says as an amateur anthropologist. His conclusion, which had policy implications for the government at the time, and he was concluding this as a mental health expert who had no training in mental health, as an anthropologist who had absolute training in anthropology, that the solution to deal with the Mau Mau problem, which was a resistance problem, was villagization. In other words, lock them up in villages, dig trenches around those villages, put stakes in those trenches so that nobody can escape, and then control movement in and out of those villages. So those villages mutated over time and became the concentration camps in which many of the people who are resisting British rule were locked up in. And it is the scholarship of people like Carothers and others that I will show you in a bit that legitimized these interventions. And they were all coming at it from a mental health and neuroscience perspective at the time, as the experts of the time. This is some of the work. This is Nature, December 23, 1933. And a pathologist called Gordon, working with somebody called Vint, published this work, which I think it bears a moment to just go through. He found in his very, very scientific endeavor that the average cranial capacity of the natives was about 1,300 cubic centimeters, as against the average European volume of 1,481. Very precise measurements that he made comparisons of pathological specimens that he measured. He said there was an element of uncertainty that was introduced by the fact that the cranial capacity and therefore the size of the brain is calculated from measurements taken on the head of the living. And this was neutralized because he examined 100 brains, which confirms the evidence that the cranial capacity, giving an average weight of 150 grams, is less than the average brain of the European. So this is science at the time that indicated that people who look like me had smaller brains than people who look like Gordon. Carothers then, in his growing grandiosity, managed to write a monograph for the World Health Organization, in which he described the African mind in health and disease, a study in ethnopsychiatry. Remember, Carothers had no training in ethnopsychiatry or anthropology or anything, but this was based on the work that he did traversing Kenya and other parts of Africa and just observing the natives and arriving at certain conclusions. And in that monograph, he repeated what Vint, who was another pathologist working in East Africa, concluded in his article in one of the most prominent journals. From the average weight of the native brain and from measurements of his prefrontal cortex, I have arrived in preliminary investigation at the conclusion that the stage of cerebral development reached by the average native is that of the average European boy of between 7 and 8 years of age. So this is the information that was being fed to the colonial government at the time. If you want to manage these individuals, treat them as a European boy aged between 7 and 8 years of age. And he says the cells also, the quality of those cells were immature. And it was impossible to say how many would mature under conditions of life and education different to those which normally obtain at the time. So the cells were also qualitatively immature compared to those of the average 7 to 8 year old European boy. And so these are the publications. This is a justification that was used to violently suppress any political dissent, because who would want to be ruled by a 7 or 8 year old European boy? And so when the Mau Mau uprising erupted at that time, it was suppressed with force, it was suppressed with violence, concentration camps were created, people were thrown into those concentration camps, and psychiatry at the time would justify those interventions. So these are just some of the images that were captured during that uprising, how the people were treated who attempted any dissent. This gentleman is called Dedan Kimathi Washuri. He was the leader of Mau Mau at the time. He was captured, he was tortured, and he was killed on February 18th, 1953, I believe. And so from this population, when I was doing my residence in psychiatry, then I managed to get about 180 old men and women who had lived in those concentration camps 50 years later, and attempted to assess them for post-traumatic stress disorder at the time from around Nairobi and the environs of Nairobi. And in that study found, and as expected, that about 2/3 of them had severe symptoms of post-traumatic stress disorder, unaddressed for the most part, 50 years after their incarceration in those concentration camps. And more than 3/4 of them had experienced symptoms of PTSD in their lifetime. And so this this is the situation that obtained until the late 50s and early 60s. The British took the Indian Mental Health Act, which is what they were using for treatment in Kenya, and in 1959 applied the Mental Health Act of the UK in Kenya, and this remained in force past independence up to 1989, when we wrote a new Mental Health Act in Kenya. Only a couple of years ago did we revise this Mental Health Act to reflect the realities of our new dispensation constitutionally, as well as what's happening in the country. And all this time, there was a policy vacuum in mental health in Kenya. So a lot of the things that we were doing were informed by stuff that was being done in the UK and in the Commonwealth, rather than information that was generated in the country. The 2010 Constitution mentions mental health as part of the health, and says that every person in Kenya has the right to the highest attainable standard of health. And so in 2015, we were able then, basing on the new constitution, to promulgate, to develop a new mental health policy, which was launched and provides a foundation for what is happening in Kenya today. So some of the policy directions in the new mental health policy included leadership and governance issues, areas around human resource that affect the entire health landscape, but mental health is severely constrained. We have about 150 psychiatrists in Kenya today. We have fewer clinical psychologists than that, and even fewer mental health social workers and other people involved in mental health. And this is a huge area that requires to be addressed. Financing, again, a lot of the financing in the budget went to paying the few people that were employed by the government in mental health, very little in infrastructure development or service development. The policy also discussed issues around substance use. Huge problems. The emerging substance use problems in Kenya include injecting substance use now that is emerging in the country, including use of opioids, use of stimulants like cat, use of cannabis, and so on and so forth. And then the policy also discusses how mental health services would be provided holistically to reach all those in need. It talks about health products and technologies and how people will have access to medications, an information system to ensure that patients who are seen for mental health problems, the information is captured in a way that is accessible to future providers, the infrastructure that is required, and then advocacy. And important areas of advocacy that we have been focusing on over the past few years include the area of suicide and decriminalization of suicide attempts. In Kenya, we inherited the British laws that criminalize suicide attempts, and we haven't changed that in the penal code for 100 years. So we are involved in an advocacy campaign with the legislature to try and repeal that section of the penal code, but also in the Constitutional Court to declare that law unconstitutional. And the second thing that I am involved in advocating for is decriminalization of substance use, in the sense that the main concern that criminalization of substance use, cannabis is criminalized, using certain kinds of traditional liquor is criminalized, using quite a range of substances is criminal, and you're found using them, you go to jail. We think that if the concern, which is real, is that some people have problematic substance use, but then we should take a public health approach rather than a legislative approach. And then we have vulnerable groups in the country, including ethnic minorities, including children, women, who are treated very differently in the society. And we focus on that as well. And then taking sociocultural issues into consideration. Taking into account that Kenya, like most of East Africa, and I would dare say most of Africa, are societies in transition from certain lifestyles that were pre-colonial to lifestyles that are having to contend with rapid urbanization and globalization and conflict between cultural practices and some of the things that we have put in our policy and in the law. So all that was taken into consideration. In 2019, there was a concerted campaign by the Kenya Psychiatric Association and other mental health providers in the country to make mental health a national priority. And in June of that year, on June 1st is a national day in Kenya, the president had this because there was a lot of social media campaigns, there were a lot of street campaigns and so on. And the president had this and declared that there's a crisis in mental health and formed a task force to look at mental health in Kenya and provide a way forward on what needs to be done. I was privileged to sit on this task force, and we sat from November 2019 to February 2020 and produced a report of this task force. And at the time when we were winding up the task force, COVID hit the country, and it highlighted significantly some of the challenges that are inherent in the health system that were exposed, including in the area of mental health. And so the task force report, which we gave the president in July 2020, was very well received, and the government committed to implement this. Some of the areas, we had these recommendations summarized into 14 different areas, including an advocacy issue of declaring mental illness a national emergency of epidemic proportions because of how we had been treating it over time. And all this, and this is available online, and people can engage with it. But the important thing is that the government at the time committed to implementing this task force report and to provide resources to ensure that that happens. One of the things that we recommended, number 4 here, is fast tracking the creation of the Mathari National Teaching and Referral Hospital as a semi-autonomous government agency. And in October of 2020, the president gazetted the hospital as a semi-autonomous government agency and created a board for it. And I was asked to chair that board, and I still chair the board to this day. We were given certain resources to start the work done, but we haven't completed the process of completely delinking it from the Ministry of Health in order for us to have full control over what we do with the board. So having laid out this landscape, what are some of the emerging opportunities in mental health, especially with an eye to potential collaboration with people here in the US and in other parts of the world? So we're looking at care. We have a population of 50 million, in fact, more than 50 million now, and we have about 150 psychiatrists. So obviously there's room to collaborate in care and in thinking about innovative ways of delivering care to people who do not have access. And we need to increase, the psychiatric care teams across the country, to increase the quality of care, and there are opportunities to collaborate in that regard, both at the Aga Khan University where I work and at Mathari Hospital, whose board I chair. As far as education, there are only 2 residency programs in Kenya in psychiatry, at the University of Nairobi and at Moi University. And we are thinking about doing this, but at Aga Khan University, it will be a long-term thing, which we might do in the next 4, 5, 6 years. And again, there will be opportunities to collaborate with institutions such as BMC and Boston University in enhancing the training programs, but also in collaboration in student-faculty exchange and so on. We have started a new MD training program. We call it MBCHB. The students are in their first year right now. And when they get to their clinical years, again, we will be looking at opportunities for collaboration with student exchange and student experience. As far as research is concerned, we haven't done as much as we should. So a lot of the statistics that are cited as far as mental health is concerned are based on estimates, usually from WHO and from other international agencies. We are currently planning a national survey, and this is a huge opportunity for us to generate the data that will then be used to inform policy, inform education, inform research. The evidence we have are from numerous small studies that we have conducted across the country, and all of it suggests that there's a huge and heavy burden of mental ill health across the country. My own personal research focus has been around psychiatric epidemiology. So a lot of the work that we have done is in psychiatric epidemiology. We are now starting to think about interventions based on the data that we have generated. I have focused a lot on trauma and post-traumatic syndromes. And again, there's opportunities to work together in those areas. Youth and adolescent mental health. We had a long study looking at orphans and separated children in Western Kenya, looking at their mental and physical health outcomes. And again, we still have that data, we still have those cohorts and the opportunities for collaboration. And lately, we have started thinking about the genetics of mental health, or mental ill health. We completed a 5-year study called NeuroGap, which looked at the neuropsychiatric genetics of African populations, focusing on psychosis. And now we are doing a similar study for post-traumatic stress syndromes. Lately, we have started looking at data science and machine learning, and we have a grant called DSI Africa, which in our institution has been translated as UZIMA. UZIMA means life, but it is utilizing data science for various outcomes, including mental health and maternal and child health. These are just some of the work that we have. So it's an example of some of the small studies that have been conducted. This was conducted by my late colleague, Dr. Edith Kwoba, in Western Kenya, looking at psychiatric morbidity in a community sample. And the most stark finding from this work was how much suicidality there is in the community that is unaddressed and identified. But 1 in 8 people indicated that they have had suicidal ideation or suicidal behavior in their lifetime. We looked at cash, unconditional cash transfers for orphans and supported children. And one of the findings here was that families that received cash transfers, families that were taking care of orphans and separated children and received cash transfers, everybody in the family did well, not just the child that the cash transfers was targeted at. And they had better mental health outcomes and so on. We've looked at physical health and mental health in Western Kenya. And this is some of the work that we're starting to look at now, the neuropsychiatric genetics of African populations. We're starting to put out publications from this work more recently. And from our data science work, this is a description of the methodology that we are engaging in to do the data science work. Then at around the time of COVID-19, I was working with an organization called Cities Rise. And our biggest focus became making cities mental health friendly, especially for young people. And so we have continued that work even now and targeting Nairobi and how it plans, how it's organized. And I think we have moved now. This work has moved to Cape Town in South Africa. It's been going on in India, in Chennai, in Bogota, and many other places. And we've just recently published work that involved asking young people around the world what a mental health friendly city for them looks like. And this was published a few weeks ago in Nature. And finally, another huge opportunity for collaboration is around climate change and mental health. And we've been looking at, in Kenya, we have a cohort at the coast of 100,000 people. We look at mental health, maternal health, child health outcomes related to extremes of temperature, flooding, and climate events. And we have just started engaging in advocacy around the area of climate change and health, and climate change and mental health. So I hope, this has been a very broad treatment of the subject relatively quickly because I would like us to have a few minutes for discussion. But the goal is to show that we've come from a place of darkness where we didn't exist as Africans, let alone having any mental health issues, to a place where we are now proactively working to advance the mental health agenda in the country. And COVID-19 has really played a huge role in throwing up our weaknesses as far as mental health is concerned. There are many opportunities for us to collaborate, and I would welcome, people coming up and suggesting what areas we can work together and how we can work to advance both the mental health in Kenya, but also what can we learn in Boston from what we are doing in Kenya, and what can we learn from Boston and apply it in Kenya. I thank you very much. Most of you would be familiar with these kinds of pictures. This is how Kenyans behave. Thank you. Yeah.
All right, so we thank you so much, Dr. Atwoli, and for speeding through slides so we'd have time for questions, and I know we'll have a lot of really great questions. So if anyone wants to ask questions, you can either put them in the chat or unmute yourself and turn your camera on to ask to the group. But we also have some folks in person, so if anyone here also has questions.
Want to stop screen here?
Oh, yeah. Oh, share.
I have a question.
Yeah.
Thank you for the excellent presentation. You always do excellent presentations. So you've been here a few days with us at Boston Medical Center and Boston University. So what has this, in the meetings that you've had, has it generated any ideas of about future collaborations or things that we can learn together?
Yeah. One thing that strikes me about my visit here this week is the similarity of the populations that we serve. You serve a very diverse population, a population of people from all over the world, I mean, if we may say so. And this is the same population we serve in Nairobi, because Nairobi is a very cosmopolitan global city that has everyone. And so there's similarities there. And there's plenty of lessons to learn from each other about how to manage these populations. So obviously the problem of people with what we might call suboptimal social support here in Boston is higher than you'd find in Nairobi, because most people we see in Nairobi will come with a relative, will come with somebody who will take care of them when they're vulnerable. And that's not necessarily the case here. And so there are those differences, and I see opportunities for collaboration in how to deal with this. Unfortunately, as Nairobi continues to globalize, as Nairobi continues to grow as a megapolis, we're going to have to confront similar problems as you're confronting here in Boston. And we would like to learn how you are handling them, how you're dealing with them, and how we can work to prevent or slow down the march towards that kind of situation. As far as education is concerned, there's plenty of opportunities. We are going to start a residency program in the next few years in psychiatry. And my hope is that we would have an opportunity to have residence exchange, to have faculty exchange, and to think about common modules sometimes of learning in global mental health, which I think is key for everybody. In research, there's huge opportunities for collaboration. I think you can look at Kenya's landscape as an explored territory in many, many ways. We're just starting out on research in data science and machine learning. We're starting out in genetics work. And there's a lot of opportunity for us to compare what is found here and what we're going to find in Kenya. So I see plenty of opportunities from my conversations. I see people who are very open for collaboration. And I think we already have at least one platform, the Africa Global Mental Health Institute, through which we can start pushing some of these collaborative ideas.
Great, thank you.
Thank you. Bonga.
Yeah, thank you so much, Lukoye. I don't know if people online can hear us, but can hear me when I'm back. I think what struck me the most about the history,
Yeah.
was that there was collective suffering in Kenya so many, many years ago. And so surely we as public mental health people, not just mental health people, we should also be thinking more about collective healing. Can you tell me a bit more about your thoughts on that? I think that's something that we should explore in Durban or in Nairobi or maybe even in Boston.
Yeah. I think you're absolutely right that populations were treated as collectives by the colonial government and to some extent by the successive post-independence governments, which treated sections of the population collectively and caused lots of harm. So taking an example from what happened in South Africa with the Truth, Justice and Reconciliation Commission, which was a powerful space for catharsis, but also a powerful space for people to deal with a terrible past in a way. It is, I agree with you, necessary for us to start creating forums and spaces where people can collectively discuss what happened in the past and how that has affected them today. It's amazing to me that we still talk about what happened in 1939 to 1945 in Europe, where a population collectively was demonized and treated in the most inhumane way, and that this continues to affect generations after those events happened. And this was 1939, 1945, with a long history behind that, of course. And in Africa, same things happened. I mean, from the days of slavery, where populations were treated as objects. And this continued up to the mid-90s, up to 1980s when Zimbabwe was gaining independence. So this is still very real for us. It's still very active. It still influences the decisions our governments make. It still influences decisions parents make when they're taking care of their children. And I think we have to think globally, from a global perspective, how to start dealing collectively with the harms that were targeted at groups collectively. It's not going to be easy, and I don't think we can lay this responsibility on the populations that were affected only. I think we have to go back to those that caused these harms and start asking, how can we work together to create those platforms where people can collectively start healing? As long as we see ourselves as different from the people in the UK, whose ancestors or forefathers caused a lot of the harms that we are dealing with today, we are not going to make much progress, I think. In South Africa, it was the perpetrators who are present and local, confronting or being confronted by the victims of their transgressions. And I think that was a powerful model that we can replicate. And I think Rwanda also attempted a similar approach, where they brought people after the genocide, the perpetrators and those whose families suffered, together in the same space, so that the suffering is expressed in that space, and those that cause the pain can see the pain that they cause. I see Alison's hand is on. Maybe she can just unmute and speak.
Yeah, thank you so much for this talk. It's very informative and inspiring. I had the opportunity to go to Moi when I was in Child Psych Fellowship, and I'm curious what your hopes and dreams are for child and adolescent psychiatry training in the programs in Kenya.
Thank you very much, Alison. I think this is absolutely spot on. We have probably 2 or 3 child and adolescent psychiatrists in the entire country in Kenya. One of them is in training in Cape Town, and she will come back to Aga Khan University. And the other one is in private practice in Nairobi. and there might be one other at the Kenyatta National Hospital in Nairobi. Our goal at the Aga Khan University is once we have 2 or 3 people at our institution who are trained in child and adolescent psychiatry, that we will start a fellowship program, because this is the strength that we have as AKU, that we have a highly specialized workforce compared to other medical schools in Kenya or in East Africa. And we will start a child and adolescent fellowship in the next, so this, my colleague comes back in 2026. So by 2027, we should have a fellowship program running, and we will look forward to collaboration and support from BU, BMC as we do this.
That's wonderful. Looking forward to it.
Yep.
We're in the process of developing our child and adolescent psychiatry fellowship.
Brilliant.
So
Yeah, we can do this
we
together.
can do this together.
Yeah, yeah,
Absolutely.
perfect. I see Nelly asking. So Jane Waweru is asking if our recording will be available. I expect that it will be.
Yes.
It will be available, and we'll have it both links to it on our Global Local Center website and through.
Brilliant. All right. And Nelly asks about how white allies can show up in a helpful way. And I think this is an important point that needs to be raised. And it speaks to what Bonga raised about collective spaces where people can get together and confront painful past and agree on a way of moving forward and dealing with it. And I think whether one is white or black or any other race, such a space is absolutely important, because I need a space where I can sit and ask why my grandfather was shipped to Burma to go and shoot at people that he had absolutely no beef with, and come back to Kenya with probably post-traumatic stress disorder and die prematurely as a result of that. And we need to confront this past. And I think our colleagues in Europe, in the US, who are on the other side of this story, can play a huge role in convening these conversations and showing up and understanding the history and doing whatever they can in their spaces to start redressing those issues in ways that we can agree on. I will not, and none of us will provide the solutions of what needs to be done, but collectively, if we start together and confronted that past, we will agree on what needs to be done. And the world will be a better place, I think, if we did that. Yeah, thank you very much. Great.
Thank you, everyone. And we'll continue to have additional amazing talks like this sponsored by the Global Center for Mental Health Disparities in the next few months. So keep an eye out and join in person again.